I want to welcome everybody to this Compass to MS Care program. This is a series that MS Views and News began before COVID. All right, we've been doing this for several years already, and we started doing it virtually during COVID. But again, we've been doing it probably for about 10 years in and around rural and underserved communities around the United States. And tonight's program, I just want to let everybody know, this is supported by EMD Serono, Genentech, and TG Therapeutics. Let's give them a round of applause, virtually and in person. Yes, I can not hear you clapping, okay? But what's going to happen during this program is we are going to have Dr. Cote. Dr. Cote is an MS neurologist. She's at Memorial Healthcare Institute in Owasso, I think it's called. I'm not sure, but I'm sure she'll give you a clue about that as well. And for now, I'm just going to give the mic to Dr. Cote. Take it away.
Well, welcome everyone. Happy to be here. Happy to see everyone. So I'm Dr. Cote. I am an MS neurologist and I practice at Memorial in Owasso. So some of you may be familiar. Some of you may see me on a regular basis. Hi. And some of you may have never heard of our practice before. So I'm happy to see you for the first time and maybe we'll see you again. I have had the opportunity to work with Stuart and give some of these talks a few times now, and they're a really nice opportunity to talk about all kinds of different areas within MS. So he asked me, tell me, what are some different ideas of things you might want to speak about? And I threw out like 5 or 6 ideas, and he said, great, do all of them. And I was like, oh, okay, that's like 5 or 6 different lectures altogether. So we're going to do all of that in 40 minutes. So it's going to be more of a high-level overview, and we'll dive into a lot of different topics. And then we'll have an opportunity at the end to really go deeper into any of those areas that pique your interest and any questions that you have. So our overview is really going to be starting with wellness. So nutrition, exercise, weight management. In addition to being a neurologist and an MS specialist, I'm also an obesity medicine physician. So we spend a lot of time in my clinic beyond MS working on weight management. And so that tends to be a pretty hot topic with a lot of patients. We'll spend some time talking about things called NEDA and PIRA, so I'll explain what those are. And then we'll touch briefly on some of the future MS treatments that might be coming. So wellness in MS, and that can mean a lot of different things to different people. Some people, we think about MS, what are the treatments that we're doing? For some people, it's more of a mind, body, soul, right? What are we doing to nourish our minds, to nourish our bodies? What are we putting inside of our bodies, nutrition-wise, fitness-wise? So wellness can mean a lot and different for each patient that I meet. So I don't pretend to have the same spiel for each patient. It's really a one-to-one conversation each time about what they're looking for to feel like they're being successful managing their MS. But we do in my clinic spend a lot of time, in many cases, talking about wellness, and that will often drift towards weight, because I think many patients will feel like they weigh more than they would like to, or maybe more than they used to. I think a lot of patients remember maybe what they weighed in high school or before they got married or before menopause. And I think a lot of patients will feel like if their weight was different, maybe their mobility could be different or they might feel different. But I think what people also think is that fat or adipose tissue is this thing that sits on the body and just sits there, but doesn't really do much. And it's important to realize that adipose tissue isn't inert, meaning it doesn't just sit there like a blob. It's actually immunologically active, meaning this is part of an immune system. This is secreting inflammatory markers all of the time, right? So this is secreting and influencing the types of immune cells your body is seeing. So we call those adipokines. And you'll see, based on the amounts of adipose tissue that a person has, different ratios or makeups of the different adipokines in a person's body. So if we're thinking about wellness, I think part of that can extend to looking at, what all can we control, and that should extend to looking at adipose tissue, right? Can we leverage this in a positive way that we can help influence our immune system by treating our adipose tissue? So this is a little bit how I got interested in this area, because I think it does connect to MS. So this slide is kind of cool because this is going to show you some of the differences in how immune profiles look between lean and obese profiles, or people who have dysregulated or excess adipose tissue. So on the right, you'll see an obese profile, and you'll see less regulatory T cells. You see more B cells. You see basically more of these inflammatory cells and less of the regulatory cells. And this is not the profile we want to see, right? A lot of the medicines that are successful in MS are really reversing that profile. So when people are thinking about wellness and MS, beyond just how do I move, what do I put in my body, I think we, in some cases, can start thinking beyond that into this category of, should I be treating beyond just eating healthy, looking into weight management as part of my MS treatment? Isn't that kind of a crazy thought? Not many people are doing this yet. We're one of the first clinics really in the country that's starting to look at MS in this way. But as a segue, what should I be eating? So this gets asked all of the time in clinic, because if you Google diet and MS, how many articles come up? Like so many pages. And all of them look really fancy. Some will say go like paleo, go someone's protocol, go vegan, go ketogenic, go gluten-free, go lots of different things, right? And they all have compelling reasons behind them why you should do what they say. Many of them are really hard to stick to. Many of them might require special foods, special food preparations. They can feel really overwhelming or defeating, just the idea of trying to stick to a diet that's so radically different to what you're used to doing, that it can feel hard to even know where to start. Everybody's got different levels of comfort in the kitchen, different amounts of money to spend on fancy foods and superfoods. And diet studies are actually really hard to conduct. There's only a few nutrition labs in the country that really do rigorous diet studies, because those studies, you really ask people to live in a lab for like 6 months at a time and you control everything they eat. Not many people are willing to do that, and they're expensive to run. So most diet studies that you see, we're providing the food and you're trusting people to follow the diet. And sometimes that works, but like everybody has a cheat day. So, those diet studies are really hard to run. What I typically tell patients is if you're looking for a framework to follow, I think there is good evidence around a Mediterranean approach stemming from studies looking through the lens of cardiovascular and cardiometabolic studies, right? What's good for the heart. And in general, I've liked that approach because I think what's good for the heart is probably good for the brain. I think these diets encourage people to move towards a more plant-based diet. So a Mediterranean diet, and I write with some tweaks because when you read about Mediterranean, I think journalists mean well, but they always write one little part that I'm like, ugh, got to make one small change. So Mediterranean diet. So this is a diet that focuses more on high consumption of plant-based foods, right? So that's your fruits and vegetables, whole grain products, moderate intakes of leaner proteins, so seafoods, non-red meats. You can have small amounts of red meats, olive oils, and lower amounts of dairies, sweets. And really, this is prioritizing antioxidants, and you're limiting processed foods. There's data to support from a cardiac standpoint. And more recently, there have been some expert opinions that have come out supporting this from an MS standpoint. But really, the background of diet studies is these are very hard to conduct. But I think if you consider cost and time and just being pragmatic, I think this is a good framework to follow if you don't know where to start. But I have an even easier starting point if this feels overwhelming for you. And my tweaks, you'll notice, is I crossed out the red wine. It's not that you can't have a glass of red wine, but the journalists will write moderate amounts of red wine. People don't always know what moderate means. So like what is moderate to one might be a heavy intake to me when I hear how much your moderate is. Like a small glass of whiskey that is like 4 fingers may be slightly more than a small glass. So I'm not saying you can't have a glass of red wine here and there, but I do think that the idea of, 2 glasses of red wine a day being healthy, because that's what that old kind of statement always was, is not accurate. So the moderate red wine every day as part of the Mediterranean diet, I think is a fallacy. So I would suggest not incorporating that as part of it. But as grandiose an idea of implementing a whole new dietary strategy and starting and tomorrow's a new day and it's going to go amazing, like I think that's a huge ask, and like no shame if that's an unrealistic ask. I've never been able to overhaul my diet overnight. I think you just have to start somewhere. And these are some really good suggestions, I think, of where you could start if you're just looking for ways to start to change your diet, MS or no MS. So, prioritizing whole foods. Whole foods or minimally processed foods means the food looks similar to how it came out of the ground. So if it has been like milled, mixed, baked, and frosted, that is not exactly how it came out of the ground. It's delicious, but it's been processed. If it is a sweet potato that has been roasted, it's pretty close to how it came out of the ground. So ideally, prioritizing whole foods. Cutting back on sweetened beverages. That's an easy, small starting step, right? I'm not saying do all of these at the same time, but if you want to start somewhere, sweetened beverages is a really small starting point that you could start with. Cutting back on processed sugars is another area if someone is wanting to make a small change. Cutting back on dining out, so much money. You could save so much money if you cut back on dining out. And cutting back on packaged or processed foods. So when you go to the grocery store, a tip is if you shop the periphery and stay out of the aisles, you'll avoid a lot of the processed foods, right? In the periphery is going to be your dairy, your produce, your meat, and it's really the aisles where you're going to see a lot of that packaged processed foods. Hydrating really well. If you're thirsty, that means you're thirsty. If you're hungry, you might actually be thirsty. So remembering to hydrate well is important for everything in your body to work well. Sleep. Sleep is actually really important when it comes to hunger and appetite and wellness, and we'll talk a little bit more about that. And then another good goal for Americans is really increasing vegetable intake. So if you want to improve your diet or improve your wellness, more vegetables. The recommendation's actually 3.5 cups a day. Virtual land, I can't see you, but for people in the room, who gets 3.5 cups a day of vegetables? My hand's not going up because I don't, but Mindy, I thought you would. So for the room, well, for the virtual room, okay, one hand. I got one hand up. So yes, recommended value, 3.5 cups a day. Smoothies are a great idea. You can blend a whole bunch real fast. Add a little bit of chia seed, got some fiber. That's a great way to get some vegetables in. But that can be a really good starting point too. Rather than taking things out, what can I add to increase the nutritional content? Now, white potatoes are not the vegetable you want to add. So vegetables good, preferably not the white potato. That one, no. And then proteins. So the other thing is most American diets are pretty heavy on carbohydrates and usually a little lower on the protein intake too. And at least in the world of weight management, we spend a lot of time talking about protein. So this is a little more specific to the weight management side and less to the MS side. But we spend time talking about protein intakes and lean sources of protein. So this is not egg yolks, bacon, and red meat. This is more lean sources like seafoods and non-red meats. So sleep. I spend so much time talking about sleep. Everybody thinks they sleep good. So many people don't sleep good. Sleep hygiene is terrible for so many people. When you wake up in the morning, you have a routine, right? You don't just roll out of bed and get in the car and go do something. You wake up, you go to the bathroom, brush your teeth, you brush your hair, you get dressed, you have a routine, right? There is a routine to starting your day. The same should exist for going to sleep. There should be a routine for bedtime. That means turning your devices off, transitioning your mind to say, okay, it is now time to go to sleep. So to turn a TV off or turn a device off and then pop into bed and expect to sleep is not exactly a routine. That's just trying to shut everything off after going 60 miles an hour. So sleep is important, but you should have a routine to help you transition. Not enough sleep is a metabolism killer. It also increases inflammation, right? We talk about wanting to decrease inflammation and do the right thing by way of your immune system, but not enough sleep pushes that in the wrong direction. If you're not sleeping, those are windows of time for snacking, right? Weight management, we want less time of snacking. But also when you're tired, that's going to influence what you do during the day. People can be grumpier. It's going to influence what their cravings are looking like. And you're less likely to be active if you're exhausted. So physical activity, the formal recommendation is going to be 30 minutes 5 times a week, or 150 minutes a week. No judgment if that's hard to do, but it's always a goal we should be striving for. Everybody's abilities are going to be different, so you have to get creative on how you might achieve this. So I'm not saying get on a treadmill and cardio, but could you get in the water and maybe do some kicks at the edge of the pool to do some water exercise? Could we get some resistance bands? Could we do some yoga as demonstrated by Mindy? Chair exercises, right? There's lots of different ways that we can move our muscles. And that part's really important because we want to preserve muscle mass. And I'll show you a picture coming up why. I snuck this slide in because this question comes up a lot around weight management in MS. Patients often ask, can I have weight loss medications? So the answer is yes. MS patients can have these medicines. These are all the different approved weight loss medicines. And there'll probably be some questions about these popping up later. So yes, they can, but they each have their own side effect profiles. Some of them can slow the intestinal tract down, and MS patients already deal with that. So that's the major thing to be mindful of, is some patients will need a little extra attention around that particular side effect to make sure that we're keeping those bowel movements moving. So I think I'm doing okay on time. So I'm going to dive into this one a little bit more for you guys. So the first one you may or may not be familiar with, that's orlistat. Orlistat was a fat blocker. So basically, if you ate food with fat, it came out as a slimy, loose stool. It was not popular. The over-the-counter brand was Ally. You might remember that from like CVS and Walgreens. Not a fan, not a hit. Phentermine is a daily medication, came out decades ago, super old, but still around because it can be effective for some people. They added a little topiramate to it, which you might be familiar with from a migraine prevention standpoint. Topiramate's also a seizure medicine. That combo is called Qsymia. Contrave is a combination of bupropion and naltrexone. Bupropion is an antidepressant that some of you might have encountered before. So those are all pill options. And then in the bottom, you'll see 3 listed as GLPs. So those are the shots that you saw all those articles written about, right? They got all that attention. They're actually not a new concept. They actually go quite far back. When I was in training, gets older every year. It was a while ago now. I used to didn't mind saying the year, but now I feel like enough years has passed that I kind of don't like saying the year now, but it's over a decade ago. I was taking care of a patient, and she had a brain injury to the satiety center, so the part of the brain that let her know when she felt full. And basically it unmasked insatiable hunger, could not stop eating. I'd read about it, but I'd never seen it before. And I was in the room trying to talk to her, and she couldn't really pause eating to talk. So she was eating in between bites. And in the time I was in there, she had finished like half a tray of a package of Oreos and had gained about 80 pounds in a few short months because the eating had just been relentless. Like food was falling in her lungs, like she was in trouble. And the endocrinologist who we had reached out to had mentioned that first medicine, Saxenda, and we ended up getting access to it out of like a compassionate care program. And it worked. It stopped her hunger. It stopped the eating. Eventually, her brain healed from the attack. and we got the weight off of her. She was able to come off the medicine and she got her life back. But it was the first time I ever saw that, and I saw what that medicine could do because it truly saved her life. I thought she was going to die from overeating. I'd never seen anything like it. But it was my first real introduction to that class of medicines, and so I have always greatly respected what that could do used in the right hands for the right patient. So these medicines are not new. The concept is not new. The media attention is new. And I think was very interesting to see, because I think obesity is a complicated disease and people have a lot of strong feelings about weight loss medications. But I will say it can be a wonderful tool to treat a chronic disease when used for the right reasons for the right patient. The other confusing thing about them is you'll notice that the bottom two have two names. So this is kind of silly. It is the same medicine, but it has two different names based on what you use it for. If you use semaglutide for weight loss, they call it Wegovy. If they use it for diabetes, they call it Ozempic. Same identical medicine. Tirzepatide, if they use it for weight loss, they call it Zepbound. If they use it for diabetes, they call it Mounjaro. Same identical medicine. So they make that really confusing for the patient because they'll say, call your insurance to see if you can get a prior auth. And they'll say, well, we don't cover Zepbound, but if you get a prior auth for the Mounjaro, we'll cover it. But if you don't have diabetes, they won't necessarily cover it, even though they're telling you they'll cover it with a prior auth. They make it very confusing. But in essence, these are the same medications. They just name them differently for the different conditions. So, sarcopenia. Sarcopenia is basically when people are losing their muscle mass. So when people lose weight quickly and they don't preserve their muscle mass, they will develop what we call sarcopenia. And people who are at risk tend to be people who are more mature, so ages 60 and up, people who are not eating enough calories and protein, people who have a more sedentary lifestyle, and people who have long-term inflammatory conditions, malnutrition, obesity. And so that does match the profile of a lot of our MS patients. And not that they're sedentary on purpose, but they may have mobility limitations that I think would equate to not being able to be as active as they want to be. And so for patients who are purposely trying to lose weight or just in general are not able to be as active as they want to be, sarcopenia is something that we think about and worry about. And so when we talk about increasing that protein consumption and resistance-based exercises, this is really one of the reasons that we care, is we're trying to prevent sarcopenia or this muscle atrophy, because you can see the differences on these MRIs. So that resistance training is key. If you love cardio, that's fine, but cardio is not going to help undo the sarcopenia. That's really that resistance or strength training. So any movement is great, but if you want to preserve your muscles, really it's the resistance that's going to get you more of that. We've talked about the wellness aspect, but patients will ask me, how do you know if I'm even stable? Like, I'm doing all I can, I'm eating right, I'm being active, but how do you even know that what I'm doing is working? And there's a couple of different ways to answer this question. One is this idea of NEDA, or no evidence of disease activity. So this really started as an endpoint in clinical trials. Like, how do you decide if a drug is working well throughout a clinical trial? So no evidence of disease activity. And this is both like obvious in your face, but also like subtle under the surface. Are things totally stable? Because someone might say they feel fine, and then they find out their MRI was not stable. And you're like, well, what the heck? Because I feel fine. What do you mean things aren't stable? So NEDA, or no evidence of disease activity, that stands for really three things when this idea first came out. The first was no relapses. The second was no EDSS progression. I'll talk about that. And then the third was a stable MRI, no new or active lesions. And I picked this MRI because this is my favorite MRI. This is both my favorite cut of an MRI and my favorite type of lesion. So this cut is you're looking sideways and we've sliced through your brain. And these scars here are really pretty. So these are like classic MS scars. If you said I've never had symptoms, I'd say, well, your brain still shows MS spots. Like these are classic. So they're radiating, they're teardrop shaped. Those are those beautiful Dawson's fingers. Those are classic MS spots. So EDSS progression is this really convoluted neurologic exam that we do. And we basically take your exam and turn it into a number, and then we keep track of that number throughout the study. Because how do you really compare one person's numbness to another person's blindness or weakness? You give everything a numerical value, and then you track that number. The problem with this scoring system is it really heavily weights some symptoms more than others. And so it's really not always going to pick up subtle changes. It really picks up certain types of progression more than other types of progression. But at the time, it was the best we had. They got fancier though, like as MRIs got better, as detection software got better, they added in a fourth metric, and that was no significant brain volume loss. So not just no new scars, but also that your brain's not shrinking faster than it should be. Because we know with MS, your brain shrinks a little faster than average over time. And so we want on treatment that your brain is shrinking at the same pace it should, not faster than it should be. So from a clinical trial standpoint, those are sort of the things you're trying to hit. But a question I have is virtual world and real people. Who in here has had an MRI and they thought for sure, like, things don't feel right. I know this MRI is going to show a new lesion. Who in here has felt that way? Okay. One person is admitting. So they thought for sure, things aren't feeling awesome. I bet that MRI is going to show a change. So I only have one to ask, but were you surprised if that MRI was stable when you thought it might show a change? Yes, there was no change on the MRI. And I will bet for people in the virtual world, there are moments where you thought that MRI was surely going to look different, and you felt very surprised when you were told your MRI is stable. And you're like, what the heck? What do you mean it's stable? I don't feel stable. So there's a couple of terms we can go over: relapse, recrudescence, and PIRA. Relapse. People always love to ask, what is a relapse? And this is kind of in my head how I think of a relapse, but think of Tron and like the neon bikes racing, because it's not this color, it's like Tron colors in my head. So when people are telling me about a symptom, in my mind, I am mapping out the neuroanatomical pathways of that symptom. So as you're talking, I am mapping out where those pathways live. For however many symptoms you're telling me, I'm mapping them. And either they all converge into a single place or they don't. They converge all over the place or they land in one spot. If those symptoms all converge in one spot, that could be suggestive that there's a problem there. And when I image that area, I'm looking to see, is there damage there? And if there is, and it's new, that's concerning for a relapse. If someone's symptoms are localizing all over the place like this, then I know that's unlikely to be a relapse, because there would have to be 13 new lesions, and MS generally doesn't do that. So a relapse is really new symptoms that when you have them localize or map back to a single location, and when we image you, we see a new scar, right? Usually they're symptoms you've not had before, but sometimes they can be very similar to past symptoms, right? If it's on a spinal cord, they might be similar symptoms each time, but often they're going to be slightly different and not identical to past attacks. Usually symptoms are going to be present at least 24 hours, and you should be feeling well while it's happening, meaning not febrile or super sick at the time of the symptoms. So that's different than a recrudescence, which is recurrence of symptoms after they've improved. So a pseudo-flare. And recrudescence usually means something's wrong inside, like stress, you're sick, you're sleep deprived, it's humid, something's up. So recrudescence is not because of a scar or your treatment failed. It's because something's just bugging the system, and because of it, the symptoms are shining through. Now, PIRA is the last term to talk about, and PIRA stands for Progression Independent of Relapse Activity. So PIRA is a newer term that some of you might be familiar with, but some of you might have never really heard this term before. In the old days, you might have heard the term secondary progressive MS. I think most people are familiar with that idea, right? Secondary progressive MS is this idea that you have your attacks, and then at some point, things turn progressive. What happened over time, though, is really good treatments came out, and they were very effective at stopping attacks. And what happened is we were able to really see what MS looked like without attacks. And we learned there wasn't really a secondary progressive stage. When we took out attacks, what we saw was PIRA, that there were these moments of progression happening even at the beginning of MS that had nothing to do with relapses and weren't necessarily secondary progressive. We just couldn't see them, and we weren't expecting them in a young person at the early stage of MS. So what we thought was this two-part, first part of MS, second part, secondary progression, was really relapses and PIRA intermixed. We just couldn't really see it. So we're really, I think as treatments come along and we're able to silence these different parts or peel back these layers, we're better able to appreciate really the pathology of MS, but still there's so much more to learn. So this picture here I really like, because what this is trying to show you is really the experience of having MS. So imagine you are this fishbowl, and this level here is how much water your brain started with. And every year that tank drains a little bit more. And that tank or that water level is what you notice symptom-wise, right? Your threshold for noticing things. When your tank is up here, don't notice anything. There's no bumps poking up, no symptoms, you're doing fine. But as that tank drains year by year, because a little bit's evaporating, you're getting a little bit older, cartwheels are a little harder, all-nighters are a little harder. As that tank drains a little bit, suddenly we start to notice a little bit of these bumps. Now, where the bumps are located matter, because each of these bumps are scars. And you may have been told where the scars are located has different impacts. So I often tell patients, the brain can hide a lot. Spinal cord, you tend to notice. And the spinal cord is this region here in the shallow water. Brainstem's in the middle, and your brain is actually the deep water. So you can hide quite a bit of scarring in the brain and not necessarily notice it's happening. That's why MRIs are so important, because you can't always trust how you feel. You got to look. But you may have to have the water level drop quite a bit before you notice that these bumps are accumulating. You might not have to drop very much before you notice it over here. But what this is showing is as that level drops, you may start to notice a little bit of symptoms from old scars starting to kind of shine through. And not necessarily because of new attacks, but because these old areas of damage are a little harder to compensate for. So you're starting to notice a little bit more. What that means is it's really important to do all you can to keep that water level as high as possible. So things like wellness, diet, nutrition, keeping your inflammation low, things that help keep that water level full matter quite a bit. Also, keeping the bumps as few as possible matter quite a bit. Now, how you judge progression, if you ask a neurologist, you get like 20 different answers. I did a 2-day conference of neurologists where we decided what was progression, and after the end of 2 days, we still didn't agree. And it was like 2 days, 8 hours a day, 20 of us in a room, and at the end, we were all still arguing. For some, cognitive changes, for some, hand coordination. I think there's many ways to look at progression. I think they're all correct. I think if there's changes to a patient that are meaningful, that's progression. So future areas of interest, I think we're going to finish like perfectly on time. So 1, we're still looking at stem cell transplants. So stem cell transplants. This is a quick slide just kind of showing you what that is. So basically, we are harvesting cells from bone marrow. We are wiping out immune systems and then repopulating with healthy cells from the bone marrow. And the idea is you're basically resetting your immune system like you'd reset a computer. I make it sound simple. It's a little more complicated than that. But the idea is a do-over. Won't last forever. It's not without its risks. What we're trying to determine is this better than the best treatments on the market right now, right? There's scenarios where we do consider this. It's not insane to think about, but there are people who this is not appropriate for. There are times we do think about it. What we don't know is how it compares to our best treatments. And there's studies going on right now trying to answer that question, and those data will be available in the next couple of years. There's a new class of drug being looked at called the BTKs. That sounds familiar, and you listen to crime podcasts, that is why. But this is a intracellular signaling molecule that is thought to have effects both peripheral and in the CNS, and we'll have lots of results coming out over the next couple of years as well. I have 1 minute left, so I'm going to finish on the one because this is my last slide. And then last one is there's a new mechanism being looked at called the anti-CD40 ligands. And so MS people have higher amounts of this CD40 ligand. And so we're looking at trying to leverage this pathway as a different strategy altogether. So this would be different than what we have in the market right now. Options are always nice. So if any of that appeals, come check out Memorial. We always have lots of different clinical trials. And if you're interested, we're always looking for patients. So if you liked anything I had to say or want to come meet the wonderful people I work with, here is our address and phone number. Thank you very much.
My question is you're talking about decreasing like fat cells and things like that. If you get the process that is like where they vacuum the fat cells out, will that help?
Um, Typically not in the way that you would like, because you're really removing superficial cells. Liposuction doesn't get to the cells that are in the problematic locations. Liposuction will get to superficial areas, but the problem is a lot of the dysregulated tissue is packed around organs, and that's really the fat you want to get to, because if it's actively secreting inflammatory markers and it's packed around kidneys or the pancreas or the colon, like that's the fat burden you want to decrease, because it's literally baking the organs in inflammation. So if you're eliminating the superficial, that's not really the problem area. So people can have the same percentages of body fat, but location matters. So if someone has the same percent, but theirs is held more in like the thigh and the buttock, the health risk is different than if they carry it in the belly. So someone, like two people weighing the same, but someone's is packed in the belly and someone's more of a, curvy shape, the health impact is totally different. So like that's taken into consideration too. There's something called the BMI, which is that body mass index. And one of the complaints about that is it really doesn't take body composition into consideration, and that we really have to move more towards where this fat is located to really ascertain someone's individual risk. Because someone can have a normal BMI, but if their muscle content is low relative to fat, you can really underestimate. Like someone can look thin and be quite unhealthy just based on those numbers. So removing it superficially may not be helpful if the fat is located deeper and really contained around their organs.
Dr. Cote, you talked about brain volume loss about halfway through could you elaborate? How is that metric monitored and how is it measured?
So, good question. So, most radiologists, it's sort of an eyeball of like, does the atrophy look more than they would expect for age? And that is not really useful. At Memorial, we have technology that does volumetric analysis. So it's like an AI program that runs and maps out the brain volume to give you a measurement, and it tracks it on every MRI and compares to try to tell you each time what those changes are. Even that's not perfect. There's no, I think, 100% perfect way to do it, because the brain will even fluctuate throughout the course of the day based on your hydration status. So you have to take all of that a little bit, not with a grain of salt, but into consideration. What I do think, though, is as we watch these numbers more, we'll get a better sense of what they mean. So right now, I'm mostly just watching everybody's numbers and getting a sense of how are they correlating. If someone's really affected and their numbers tend to look like this, or someone's minimally affected and their numbers look like this, is that generally a pattern that I'm seeing? And I am starting to see some patterns, more so with percentages than total brain volumes, but I'm starting to get a sense about what are okay numbers and what are more problematic numbers. But for me, I have to see something hundreds of times before I start to get a sense of what I think it's telling me. But the real answer to your question is, for us, we have AI software that we just run that tells us.
The source of that data is my MRI.
Yes. Yeah. And not totally a new concept. They did do this previously with epilepsy and brain surgeries. They would use this type of technology like brain mapping. And now it's really spread into the MS field.
You briefly touched on it, and I was following up about the AI. Wouldn't that help on measuring the different biomarkers?
So there's a lot being looked at with biomarkers. I think one of the questions still is what are the most useful ones and what can they actually tell us? So like neurofilament is pretty far along in the process. GFAP is another one that's getting a lot of traction. Those are probably the two that are farthest along. Are you thinking other biomarkers?
Just AI in general about measuring your brain mass. Are
Oh.
you implementing the AI software to its full extent?
So for what we have, it also tells us things like lesion counts, percentage of like white matter involvement, percentage gray matter involvement, like thalamic volume, cortical gray volumes. I'm starting to use percentage white matter a little bit more. I find the lesion count not accurate. I have not enjoyed looking at those numbers. The other day I had someone and it counted artifact, and I thought that was not helpful at all. So anything can be erroneous. So I think even that has its limitations. So we'll see how helpful in the long run it actually is.
I'm sorry, it's a little bit different than the presentation, but do a lot of these medications that are out right now, including even the weight loss medications, anything like that, do they lower people that end up being JC positive? Does that have any effect on their numbers or their viral load?
No. Yeah. That one was easy. Thank you.
All right, it's time for some online questions, please. First one is, person wrote earlier, this is a strange question, but you were talking about red wine, and this person wanted to know if there's a specific red wine that they are allowed or not allowed to be using with MS.
There's no studies that I'm aware of comparing different like red wine and MS component, like MS outcomes or inflammatory components. So I can't recommend a certain one.
Okay, thank you for that. As going back to the biomarkers, are you able to talk about the Octave testing?
So it is not something that we have felt was necessary to utilize within our clinics. I think we're lucky to have a lot of fellowship trained MS experts in our clinic. And so we're pretty comfortable with the training that we have to make decisions off of the patients and our imaging and our experience. So we have not found that technology useful at this time. I think there is a role in the future for biomarkers to guide, I think, community neurologists to hopefully seek help in a timely fashion from MS experts when those biomarkers are elevated, and to know that that's a signal to refer to MS centers. I think there could be great value in that.
So the question though was, are you able to speak about, just to tell people what an Octave test is versus like the neurofilament, so that way they know about that as a biomarker?
Yeah, so Octave is a panel of biomarkers that can be run that is just a bunch of different biomarkers that are sent off. And when it's done, a number score is given, and there are suggestions of how that number score could be interpreted by the person who's ordered that test.
Okay.
Yeah.
All right. Thank you for that. A person wrote, going back to things that you were mentioning at the beginning of the program, she wrote, having a room silent for sleeping is not calming or conducive for many first responders or veterans of the military. When it's too quiet, that puts us on alert. And when it's too quiet, that means something bad is about to happen. So having a TV or music or audio book playing at the low volume is better to help people in those categories to sleep better. Do you have any comment about that, please?
I like rain on a tin roof. That's the thing I play. Thunderstorms and tin roof sounds. So I don't disagree. I need a little bit of noise too.
Okay.
Yeah.
All right. Thank you for that. Next person is asking if you can, what are your thoughts on smoldering MS?
Yeah. So this is really something that is better understood as well in the more recent years. We think a lot about MS as peripheral activation of immune cells coming in and causing damage, but we also know that there are clusters of immune cells inside the brain, these little nuggets of immune cells that are smoldering or sitting there like little burning embers causing damage, right? Just kind of sitting in there, just not helping things. The challenge is not all medications can access those spaces. And the concern is that some of that PIRA or that slow change over time is in part driven by some of this compartmentalized inflammation occurring from within the brain. And is there a way that we can find medications to better address that component of MS? And if we do, could that better address PIRA or that progression independent of relapse activity?
How safe is it to do more than one MRI per year? And when would a doctor like yourself ask that a second MRI in a period of 1 year be asked?
So MRIs are fine. They're magnet. We have no concerns with people doing MRIs. If someone has clinical changes and I'm concerned that there's a relapse, or I'm concerned that there could be a complication of a treatment like an infection, then I will want another MRI. It might be a month after I did the last MRI, might be 9 months. I want it when I want it. So that's really based on the clinical changes that are triggering me to want it. Typically, if someone is starting a new medication, usually you will want an MRI 6 months after starting to assess response or rebaseline them. Thereafter, it is usually once a year. But there are, I think, other scenarios where sometimes we'll be a little more flexible. If someone's, traveling and we just really need to knock it out, that second to last week in December, sure, but usually it's more going to be driven by clinical changes, or if they've just had a change in treatment and we're doing that 6-month rebaseline.
Okay. And continuing with the MRI, are you using gadolinium in your region?
So that has changed a little bit. If someone so the purpose of gadolinium, I think we start there. When they give you the gadolinium, the purpose is to flow through your veins, and if there is no active inflammation in that moment, the gadolinium will stay in the veins. If there's a scar that has formed, the veins will be inflamed and leaky in that scar, and the dye will pool out or ooze out and light up like a little glowy spot and say the scar is right here. That's a temporary, time-limited process. So it will glow for a few weeks around the time of that scar formation. So the dye helps us identify in real time that the attack is occurring. So if someone is getting their annual MRI, they're perfectly stable, their treatment hasn't changed, and they're on a high efficacy therapy, I no longer ask them to do dye. If someone is on a low or moderate efficacy therapy and this is their 6-month scan, I may ask them to do dye. If this is urgent MRI and I'm nervous for a true relapse, I'll be asking them to do dye. If it's a follow-up on an induction therapy, I'll be asking them to do dye. But there are some scenarios where I've started waiving the dye requirement if I think the likelihood of capturing an active lesion is low. And really, it's because if I really think my likelihood of seeing something is low, then why am I asking them to do it? I don't like doing things because that's how we've always done them. I really want to do something if I need the information. And so I really try to think through for each scenario, what is it telling me and do I really need it? Because it's time, it's money. Like if I don't need it, I don't need it. But if I do, it's because I really do.
Okay, thank you for that. Now, sticking with the MRI, normally I guess you just do brain scans. When would you use MRI for somebody's thoracic or lumbar?
So if I'm meeting someone for their first time, I in a perfect world, I would like BCNT. We don't really do lumbar because there's not spinal cord in the lumbar region. It's really mostly nerves. Thoracic catches the tail end of the spinal cord. So people always ask, why aren't we doing lumbar? Lumbar looks at something different. So you really don't need lumbar for MS, and insurance won't cover that. So it really is just BCT, or brain, cervical, thoracic. So when I meet someone in a perfect world, I like BCT. If someone doesn't have anything in their thoracic spine and they're on a good quality treatment and they're stable, I may not do thoracic every single time. I might alternate it in. If someone has severe claustrophobia, I may not be asking for a really long scan every single time. For sure, I want brain every single time. And we're often getting cervicals every time or every other time. But I also tailor it to where their scars are. So if I know they have scars somewhere, I like to watch that area. But if there's areas that they don't have scars and they've had MS a long time and things have been stable and they're on a good quality treatment, I will let them start to alternate, if we have to watch those cord areas every single time.
Thank you for that. In the rural areas where you live or where you're located, or even in a Flint area, are there more 3.0 machines or 1.5? And can you tell people online the difference between the two?
So there's a mixture of both, probably more 1.5. So we have both at Memorial. We have a 1.5 and we have a 3.0. And it's really the quality of the picture. And one is a more grainy picture. The other is like zoom paparazzi lens. And I've shown patients before the difference between the two. And there was actually a learning curve for me when we got our 3.0. I had to sort of retrain my brain how things looked between the two, because scars looked very different between the two scans. And what looked like all new scars were so subtle on the old ones. It was like a whole new brain. And I had to retrain my brain to figure out what was the difference between the two versus new lesions. So the quality really is quite different. So it's not to say you have to always be on a 3, but just know if you're hopping between scans, your radiologist may give you a funny read of could be differences in machine, and they really mean it when they say that. The pictures do look quite different between the two machines. Now, the 3s will be a lot hotter. They'll probably be a little quicker. So that can be nice too if you hate being on the table.
Okay, thank you. Going back to weight management, can you tell me what you advise best for those that are non-ambulatory?
So I think it starts with deciding what the goal is. Everybody's goal is different, and making sure goals are coming from the right place and are smart. So they're attainable, they're reasonable, we have a timeline in place, they're achievable. So if our goal is, a 5% change, if our goal is to decrease a blood pressure medicine, if our goal is, it depends on what the goal is. And then from there, we figure out how do we approach that goal. But for most patients, it's a combination of dietary changes, some sort of physical activity prescription, sometimes a medication, sometimes working with a therapist, like a mental therapist, not necessarily a physical therapist. It's really tailored to the person because each person's story and journey is different. But it's never one thing, it's usually a combination.
Okay, thank you. A more difficult question coming up, and a person wants to know if you can specifically define the differences between relapse remitting MS, RRMS, primary progressive MS, secondary progressive MS, and secondary progressive MS with relapse.
So it's all the same, except think of it as a twist ice cream cone. Chocolate is relapses. Vanilla is progressive. Vanilla ice cream is your primary progressive. You've never relapsed, it's just progression the whole way. Never a day where something suddenly didn't work. But if you look back year by year, things just got harder. There was never a sentinel moment. There was never a blind in one eye. Things just got hard. Chocolate ice cream or relapsing is like every month or every year, something happened, something weird, something different. Half the time they got better, half the time they got mostly better, but it was always something different. Leg went numb, eye went blind, face hurt, foot dragged, arm got all wonky, came and went, right? Relapses. Secondary progressive is really that sort of mixture of both, right? You have twist ice cream. You have your chocolate and you have your vanilla. You have your relapses. They're coming and they're going. But later on, the relapses are less, and it's more that just things are getting harder. It's not that there's drama of things coming and going. Things are just coming and kind of staying. And nothing's really dramatic, but year by year, things are just changing a little bit. And it might be once in a blue moon, things are flaring up with a new scar here or there. So that's that sort of superimposed relapse here or there. And that's really kind of how MS is. They tried to box it, and the boxes never really made sense because it's not a different disease. It's all ice cream. It's just some people have more relapses than others, but it's always been the same disease process. It doesn't flip a switch and turn one way or the other. It's always been the same B and T cells misbehaving. It's just, for some people, it leaned a little more one way, and for some people, it leaned a little more the other way, but it's always been the same disease. It's just presented a little differently between different people. And I think trying to box it never really fit people and never really helped people figure out where they were at, because you're never really at anywhere. You don't switch one day one to the next. It's just twist cone. Sometimes it's a little more brown, sometimes it's a little more white, but it's all the same ice cream. It's kind of how I think about it.
How do you measure sarcopenia? It's a progression of the lost muscle mass, but is there something that could be a red flag to kind of check it before it gets any further along? The other question that I have, I'm going to put three right together. What's your opinion on fasting and autophagy? The cleaning up of dead and damaged cells. With the lesions, there would be some cell damage there. And my third question, just in general, inflammation. MS is always inflamed. Is there any good techniques or behavior to keep inflammation to a minimum, throughout the body and also through the brain and spine?
So we have sarcopenia. Okay. So fancy-wise, MRIs and ultrasounds, but those are going to be money. Cheap and easy would be looking at something like a body analyzer. So like gyms will have this. We have one at the hospital. So it's like this machine that you can stand on. It passes a current through you, and it does a body composition analysis where it maps out per limb percentages of muscle, fat, and water. It's not perfect, but it is a good starting point to say per limb, what pound of muscle do you have? So again, not perfect, but it's cheap and it's something to start with. But to really look at the composition of the muscle, you'd really be looking at like an MRI to really look inside and see what the muscle is comprised of. But that's not really standard of care as far as like insurance paying for something like that. Fasting has great potential. Half the neurologists in my office fast, so they're big believers of it. I think if you can incorporate it, there's some great science around it. I think some people are on medications that make that a little trickier, but there is a lot of good ideas around the idea of like intermittent fasting. In our office, they do 24-hour fasts. I don't know that I could do that.
What about the benefit of autophagy when you fast?
I don't know that I can speak to that here, but I think what I can say is there is certainly compelling data from a like telomere survival benefit, health benefit, and probably the ones that do will live longer than me, and they're smart to be doing it. Well,
All right, are we finished with the questions in the audience, please?
That inflammation.
yeah, a lot of that I think is really going to be prioritizing quality sleep and nutrition in terms of that kind of inflammation, because not all inflammation is the same, right? Inflammation when you like pull your knee is different than the inflammation of MS, is different than the inflammation of, lupus. So if we're thinking like global total body, I think for that it's really the nourishment of the body and the quality of the sleep. And truly, I mean it when I say the quality of the sleep, like adequate hours, adequate quality. If you have sleep apnea, treat it. Like that is always underestimated and matters a ton.
All right, awesome. Thank you, everybody, for being online with us tonight and for being in attendance at the program location. My name is Stuart Schlossman. This is an MS Views and News educational program. Thank you again, Dr. Cote, for being here. Have a good night, everybody. Bye-bye.